I'd like to speak about inferior oblique surgery in one of the most popular forms of strabismus, of vertical strabismus, which is superior oblique paresis, which is very common in our daily practice. Usually we face inferior oblique overaction as a primary inferior overaction, or sometimes as a secondary after having superior oblique paresis with vertical ocular misalignment, sometimes diplopia. We find the constant find of extorsion present in all cases of superior oblique paresis. We have many surgical options for treatment of superior oblique palsy, like ipsilateral superior oblique tendon tuck. I'm not fond of this technique because of its less effect and consequences. The ipsilateral inferior oblique recession is an option. We have inferior oblique myectomy. I'm a big fan of inferior oblique myectomy. In fact, anterior transposition of inferior oblique muscle. We have ipsilateral superior rectus recession. We have contralateral inferior rectus recession, and we can do selective fiber advancement like in Harada E2 surgeries. Many times we have just grade 1 to 2 or 3 inferior oblique overaction, either primary or secondary, that we can do just myectomy. It's a very simple, short procedure. Just we can get the inferior oblique, go for good dissection of the inferior oblique, avoid injury of the vortex vein, having proper exposure of the inferior oblique. One of the tips in exposing the inferior oblique is just having 2 hooks or at least one small hook resting on the sclera, just to keep the inferior oblique away from the conjunctiva and tenon that can be easily hooked. But we have to make sure we have all fibers of inferior oblique in our hook, because many times we just get some of the fibers and miss others. The other thing we are scared of is injury of the orbital septum, so we'll end with fat prolapse and fat adhesion syndrome. So after hooking the inferior oblique, we have to make sure we have the end glistening white septum. Then we can take 7 to 8 millimeters of the inferior oblique, just doing cutting and cauterizing the ends of the inferior oblique, and we have to retrieve back each part to its original place, not to have attachment in unfavorable way. Many surgeons don't want to close the fornix incision, but usually I close it by interrupted by I keep it loose for having any hemorrhages that should leak outside that loose wound, not having retropulpar hemorrhage, because secondary hemorrhage is very common after having inferior oblique myectomy. It's very effective in small inferior oblique overaction and in some small vertical deviations. And one quote I'll take from my friend Dr. Amr Kamshushi is taking one size fits all in doing inferior myectomy for many degrees of inferior oblique overaction. But what happens if we have large vertical deviation, like in this boy, having large exotropia, and he has large vertical deviation because of the right fourth nerve palsy, as showing the ipsilateral right head tilt is increasing the distance between the vertical angles between the right and left eye. In such case, I have to address 3 muscles for horizontal strabismus surgery, and again I will add 2 vertical muscles. In that one I did bilateral rectus recession and right inferior oblique myectomy, but I have to add left inferior rectus recession to have good accepted results horizontally and vertically. So the other technique I'd like to show today is the inferior oblique anterior laser transposition, because I can make double benefits of operating upon the inferior oblique to decrease its action and to have an additional antagonistic action for the weak superior oblique augmentation. In such cases, we have vertical deviation larger than 20 or 25% diopters, like in that girl. We have large left hypertropia after decompensated left fourth nerve palsy. So if we examine the fundus, we'll find large extorsion. So what I do is just transferring the inferior oblique insertion from the temporal side to the nasal side of the inferior rectus. Again, we have to expose the inferior oblique the same way we do in myectomy. We have to go for proper dissection, proper hooking of the muscle itself. We should be aware we have the vortex vein nearby, so just take care not to injure the vortex vein, not to end up with severe hemorrhage. Again, we have to make sure we have all fibers of the inferior oblique exposing the glistening septum. And now we have to start suturing the end of the muscle. Many surgeons prefer to do suturing before this insertion, but all the time I'm scared of injuring the vortex vein, injuring the sclera, or perforating the sclera. So I just take in my mosquito forceps or mosquito clamp, having securely removing the fibers, then I will start suturing outside the narrow space of the inferior oblique. After having proper suturing of the inferior oblique, now I have my securely disinserted inferior oblique muscle. Then I will start exposing the inferior rectus to go for its nasal side to fix the new insertion of the inferior oblique. Many times when I show this technique, I give the question of you are passing the inferior oblique underneath the inferior rectus because I'm everting the eye up. So when I pass the inferior oblique, now it's going underneath the inferior rectus. So measuring 2 millimeters nasal and down to the nasal side of the inferior rectus insertion, I should have proper exposure to put the fibers of the securely disinserted inferior oblique on the nasal side of the inferior rectus now. By this maneuver now I reverse the action of inferior oblique. I weaken the inferior oblique elevation, extorsion, and abduction to make it a depressor, adductor, and intortor because it's now inserted on the other nasal side of the inferior rectus. Again, we have to have proper exposure because of the narrow space may endanger the sclera and end up with perforation. Having our fibers, then we have to pass it on the nasal side, just fixing with absorbable Vicryl 6 usual sutures we use in strabismus. Then to dissect extra tenon capsule or extra tissues not to have adhesions on granulomatous adhesions. Then again, we can end up with closure of the fornix incision with a single or double interrupted sutures. This is the same girl I showed primarily second day post-operative having 25% diopters of hypertropia, and now she's almost orthotropic. Again, I can try to enlarge angles at this girl who's born with congenital fourth nerve with very large hypertropia, and I did a single muscle which is inferior oblique anterior nasal transposition on the other side. Otherwise, I didn't dream of having this accepted results without operating upon two muscles. So usually I promote for it, telling why two if one can do. It can be combined with horizontal muscle surgery, like in this girl, because this girl has small angle exotropia, so I have to operate upon one lateral rectus. So I did for her lateral rectus recession and inferior oblique anterior nasal transposition, and this is our results after 1 month of being operated. We are lucky having this study we ran in Research Institute of Ophthalmology, and we published it a couple of years ago about comparing the inferior oblique myectomy to anterior nasal transposition, and we have very, very accepted results, and we don't have a single case of we don't have a single case of anti-elevation syndrome or elevation deficit. Thank you very much.